So hello friends, welcome back to my channel Medicine of 101. Today we will talk about pregnancy induced hypertension. So another term for it we can say the eclampsia. Okay. So before starting the topic, let's talk about some basic points about the topic. So what do we mean by hypertension? So whenever basically we see the hypertension, the blood pressure that goes around, we can say the more than 140 by 90 mmHg. So when can we get consider a pregnant woman that we can see that is the word pregnancy induced hypertension. So, okay, for that thing, let's talk about this first thing first. So the first thing is over here. If we get any woman individual who is pregnant after 20 weeks of the gestation period, if we get the blood pressures, more than 140 by 90 mmHg, in these cases, we can say that there is our pregnancy induced hypertension. Now see, for this things criteria to classify, we have to measure the blood pressure in the two times. I mean in terms of the two occasions, and for around 6 hours apart. For example, whenever the pregnant woman who has come to the OPD or who has come to the hospitals, just seeing the environment, maybe she is having little bit increasing the blood pressures. So just to make sure that whether the woman is having the normal blood pressures or not. Okay, that for that thing we have to measure the blood pressure for the two times around the 6 hours apart. Okay. Now, see, before developing the hypertension in the pregnant individuals, there is one stage that is known as a Preeclamptic toxemia. That should be clear for us. Okay, first thing first. So I'm writing it over here, Preeclamptic toxemia. In these cases, just before development of the hypertension or before development of eclampsia over here, what are the clinical manifestations we will get in these cases? Okay, before developing of the hypertension. So what are the clinical manifestations we will get over here? We will get, okay, let me write over here. We will get the proteinuria, and in these cases we will get more than 300 milligram in 24 hours. This is the first thing. Okay. The second thing we'll get over here. That the protein creatinine ratio that will be more than 0.3. In these cases, or in this whenever we get this type of the clinical manifestations, then we can consider the thing that will be regarded as preeclamptic toxemia. Now from here we will get the development of the eclampsia. Okay, from here we will get the preeclamptic toxemia to eclampsia. Okay, now how can we say that we are getting the eclampsia? We can just find out the eclampsia. Basically, definitely there should be some signs and symptoms to detect any individuals that whether she is having the eclampsia or not. Okay, so what are the signs and symptoms in terms of the eclampsia? Let's know about them first. So let's write it over here. Eclampsia. Now see, in these cases we will get whatever the problem, we will get generalized tonic-clonic movement. That means the most worst form of this thing that can lead to formation of the convulsion. That means we will see here the muscular movement just like this. Okay. So we will get the generalized the generalized tonic-clonic movement. Okay, generalized tonic-clonic movement that will leads to then the severe form that will leads to formation of the convulsion. Okay, in these cases, and whatever the signs and symptoms we'll get over here for these things. The first thing, let's write it over here. Whatever the symptoms and signs we'll get, definitely you will get the headache. We'll get the headache. We'll get vomiting. Okay, we'll get the blurred vision. We'll get epigastric pain. Okay, so this type of the things if you just get, okay, just after the pre-eclamptic toxemia, then you can consider the individual having what? We can say the eclampsia. So the individual or the woman pregnant lady who is suffering from the eclampsia over here. Okay, so we'll get headache, we'll get the nausea, we'll get vomiting, we'll get blood visions, we'll get epigastric pain. Okay, this type of the symptoms. And more two thing over here, let's talk about them also because these things are important. We'll get the knee jerk, that will be present, and we'll get the proteinuria. Around we'll get more than 2.9 gram per 24 hours. Basically, in terms of the nephrotic range, it will be within the nephrotic range because if you want to consider anything nephrotic syndrome, that should be more than 3.5 gram per 24 hours. So this should be the considered as in terms of nephrotic, but we'll get the proteinuria in terms of the convulsions or you can say eclampsia. That will be within the nephrotic range. That means that will be more than 2.9 but less than 3.5 over here. Now we'll talk about the different kinds of the things. For example, I'm just talking right now on individuals who is having the pre-existing hypertension. Try to understand very carefully. Okay. See, I'm just talking for any individual who has come to the OPT. She had pre-existing hypertension. That means whenever she was around 14, 15, 16 years old, okay, at that time she was having the hypertension and it's persistent. Now whenever the lady is becoming the pregnant once, okay, at the time whatever the problem we can see in terms of the hypertension, so we'll get here over, we'll get what in terms of the pre-existing hypertension, we'll get right now the acute hypertension, so you can get the chronic hypertension, so in these cases. Now let's talk about another type of the hypertension that is known as the delta hypertension. So what do we know by delta hypertension? Now delta hypertension means, for example, any woman individuals, okay, or the pregnant lady who maintained already, that normal blood pressure level. Just let me say once more again, that any woman individuals, any pregnant individual who has maintained the normal blood pressure level till the first trimester, second trimester, and third semester. So within the all trimesters, she has maintained the normal blood pressure level. But for example, when we are just saying in the first trimester, the normal blood pressure level, second normal blood pressure level, but around 34 to 35 weeks we are getting the blood pressures around 130 by, for example, 86 mmHg, or we are getting 136, or we can just talk 138 by 88 mmHg. We are getting, for example, 140 by 90 mmHg. Now in these cases we are getting the blood pressure that is increasing. So in these cases that will lead to formations of the eclampsia. So that will lead to formation of the eclampsia. Okay, now we'll get the eclampsia that will be developed over here. Now we'll talk about the treatment in terms of the treatment of the eclampsia. Okay, so let's talk about the treatment. Okay, let's erase this part over here. Now, whenever we are talking in terms of the treatment, in terms of the eclampsia, what we are going to use over here, try to understand from these things. The drug of choice for treating the eclampsia, that will be the magnesium sulfate. That will be magnesium sulfate, MgSO4 is the symbol for it, 7H2O. Now we have to use in the intravenous route and intramuscular route. Intravenous and intramuscular. Okay. Now during eclampsia, whenever we are getting the drug of choice, this is in terms of the magnesium sulfate, we have to use first we have to use in terms of the intravenous route. Okay, first we will use through the intravenous route magnesium sulfate, the 4 gram first. Okay, then we are going to use that, we'll use the magnesium sulfate through intramuscular route, MgSO4 7H2O, we'll use over here around 10 gram. Out of 10 gram, 5 gram we'll use on buttock and 5 gram will give another buttock. Okay, so total how much? Total we are getting 14 gram. Now after giving 14 gram of the magnesium sulfate, if you see there is no relief or we are not able to control the symptoms of the eclampsia, then you can add, if there is no relief, we can add 2 gram of magnesium sulfate through intravenous route again. Okay. Now after giving these drugs, if we see still there is some types of the symptoms, okay, we have to make sure that if you see there is a chances for development of another convulsions. Okay, just before starting the another convulsions, we have to treat the patients. Okay, so in this case, if we see there is the presence of, for example, the knee jerk. If you see there is the presence of knee jerk over here, or for example, in these cases, we have to use the magnesium sulfate for the next 24 hours. For example, if I just say from here that around 12, for example, around 10 a.m. in the morning, for example, around 10 a.m. in the morning, for example, today, okay, where you have just started the therapy by using the magnesium sulfate. Then in the next morning, for example, the next morning 10 a.m. we have to use this drug for around 4 hours apart. So we have to give these drugs around the 4 hours apart. For example, I have started in the 10 a.m. in the morning. Okay, after 10 you have to use where? In terms of the 4 p.m. After 4 p.m. Okay, we'll use again when 8 p.m. Then we'll use again 12 a.m. We'll use again 4 a.m. We'll use again 8 a.m. just like this. Just before the 10 a.m. over here. Okay, 1, 2, 3, 4, 5, 6 over here. So you have to use in these cases just like this one. Now to maintain the blood pressure level. Okay, let me use this one over here. Now these are the drugs I have used over here. Okay, so these are the drugs just to reduce the symptoms of the eclampsia. Now to control the blood BP, just to control the BP, to get it normalized, whatever the drug we can use. In terms of the emergency conditions, if we get any emergency conditions where we are getting the convulsions along with the definitely there will be high blood pressures. Now just to treat these things, what we have to use the magnesium sulfate definitely. Okay, we have to magnesium sulfate along with this. What can we use in terms of the, because see in the magnesium sulfate that basically works well within the brain, so that will suppress, and as a result we will see the symptoms that are those are appearing for in terms of the eclampsia, that will be not appeared. Okay, that will be suppressed over here. Okay, now just to reduce the blood pressures we have to use what in terms of the emergency conditions, levetolol. We have to use levetolol in this way. Okay, we have to use for example 20 milligram first in the first 10 minutes. And if we see after giving 20 mg, if we see there is no changes in the blood pressures, we have to use again 20 milligrams. That means we'll get around 40 milligram over here. After that, if we don't any changes, then we have to use in terms of 80 milligram. Just like this, we can continue up to 220 milligram. You can increase the dose up to this much. Okay, just to control the blood pressure, blood pressure level. Now, as we know that the levetolol, levetolol basically is the alpha plus beta blocker. So it will block the alpha plus beta post type of the receptors over here, and that will try to reduce the blood pressure level, and it will try to take the blood pressure level into the normal level. Okay, so those are the things as far as the the different kinds of the management in terms of the eclampsia is concerned over here. Now we'll talk about The other types of the drug that can be used over here just to control the blood pressure level, we can use the hydralazine. We're going to use hydralazine. Hydralazine we can use over here in terms of 5 milligram to 10 milligram. The bolus form over here we can use. Now there are some drugs. Those are the drugs. Those are contraindicated in pregnancies to treat this type of the conditions. What are the drugs? Those are contraindicated over here. Now the drugs contraindicated. That means they cannot be given in terms of the pregnancy-induced hypertensions. First is furosemide. The second one we can see over here the beta blockers. The third one we can see over here AC inhibitors. These are contraindicators because they can cause the different types of the effects. One of the most important over here, they can cause the intrauterine growth restrictions. So these are the contraindicators. Okay, so that's all for today's the first video in terms of the pregnancy-induced hypertension. For example, just try to think in terms of the part 1, because if I just say all the points, then the video is really longer. So I don't want to make the video that much longer. Okay, so I'll just keep uploading the videos the part by part. Is the first part. In the second part, we'll talk about the etiology of the hypertension in these cases. Then we'll talk about different kinds of the managements. More managements are also over here when different kinds of the emergency conditions. So thanks for watching. See you in the next video soon. And please like and subscribe my channel.